Thank you for joining RhPAP and our rural community leaders for today's Knowledge Now session. I'm Shanda Burns. I'm the Senior Manager of Community Development and Engagement here with RhPAP, and I'm pleased to host today's conversation spotlighting the realities of healthcare in rural Alberta and the solutions being driven by communities themselves. Across rural Alberta, healthcare challenges can feel complex and persistent. I think we can all agree with that. But with those challenges comes resilience, collaboration, and leadership, also grassroots action. You'll hear firsthand stories from 3 communities who are tackling physician retention through a unique clinic model, supporting and integrating internationally educated nurses so they can thrive in rural Alberta, and advocating locally to strengthen healthcare access through organized community engagement. These are practical lived experiences, and we hope you leave with ideas that you can adapt to your own context. So a little bit of a session overview. Today, we'll be following a structured panel format, and each community will walk us through their local healthcare challenge, the turning point, how they moved from idea to action, the barriers they faced, what made it work, and what changed as a result. So without further ado, we're going to begin with Grande Cache. So joining us today, we have Jackie Mines, Board Chair of the Grande Cache Medical Clinic Corporation Board. Jackie is a retired educator of 33 years, including 11 years as principal of Grande Cache Community High School. A 49-year resident of the community, she has been deeply involved in establishing and guiding the current clinic model from its inception. We also have Tina Tippie, Vice Chair of the Grande Cache Medical Clinic Corporation Board. Tina moved to Grande Cache in 1977 to work at the hospital as a laboratory and X-ray tech, later serving as supervisor in diagnostic imaging. She has long been an advocate for sustainable healthcare and helped build the newly formed not-for-profit clinic board. Thank you both so much for joining. And we're going to jump right into the panel questions. So the first question for you 2 ladies is, tell us about your community and the healthcare challenge that you were facing.
We had a community of people that got together to form a small board to bring in or to attract physicians over a period of time. We have a clinic, or had a clinic at that time, that had 5 physicians in it, and we were looking at the fact that some of these physicians would be to a point of retirement coming up. So the question was what would happen with that clinic when they retired? And unfortunately, how it ended up happening was that during the fact that they were retiring, it ended up that the clinic was going to end up closing. So these community members got together and decided to try and figure out a way of keeping this clinic up and running and how that was going to be accomplished. So because everybody knows everybody in a small town, they started talking around with each other and came up with kind of a plan that might work. And what ended up happening is that through various people and asking various people if they'd be interested in helping out with this project, we ended up with a board of local citizens that got together and did some brainstorming as to how to move ahead with this project. So eventually what ended up happening is we formed a board, we came up with some ideas, we had to do a whole lot of research as to how we were going to accomplish this, how we were going to get funding, and so on and so forth. So we ended up forming a non-for-profit organization, which I believe is the only one in Alberta at this point in time, to manage and operate this clinic. And our ideals were to try and manage it in a way that the physicians would just have to show up, see their clients, see their patients, and we would handle everything else, the staffing, the supplies, the whole gambit. So that involved a whole huge process of going through the government, finding out what we needed to do and going through it, and we worked really hard and accomplished it.
So what was the moment your community realized that something did have to change, especially within that clinic model?
We had no doctors. We had only one left, and he was working out of the Emerge. So for a number of months, he worked out of the Emerge. And then the Bighorn PCN out of Hinton decided to open a temporary clinic for a short period of time, allowing us the time to get organized. So yes, we became a non-for-profit board, but when Tina was speaking, they had tried to engage the MD several times, but MDs don't give money to private businesses. So because we were a non-for-profit, we had the option of approaching the MD for funds for sustainability. So originally we went to them in November, and then they told us we needed a business plan. And so here we are, 7 people forming a business that we know nothing about. So we engaged Community Futures to help us with that plan. We built this big business plan. Then we had to take it back to the MD, and they agreed. It was a lot of work. It was 8 hours a day for many months. So they gave us money in February, but we didn't receive it till March, and we opened the clinic in April. So we had to do everything. We had to do HR manuals. We had to get I'm going to say it wrong, Tina, Privacy Impact Assessment. I always want to call it a
Good
beer.
job.
Privacy Impact Assessment done. We had to buy all the furniture, all the computers. And at that time we had no money. So it was a little crazy because lots of just about everything went on either my credit card or Tina's credit card. And then when the money was in there, they wouldn't give us any banking, any credit cards. So as soon as we paid it, then once we got the money, it was getting paid back. So we went through a really tough time getting that clinic, and we had it renovated. And we opened in April of 2022, and it's been running for 3 years.
In terms of action steps in recognizing the problem, what would you say were some of the key action steps? You recognized the problem, you went into action, but in between, what was the vibe there? Kind of how did you move forward?
Well, I think we have a very strong team. We're very multifaceted. We've got people from all different areas, and it was either that or no doctors in town, one person, that was it. And I think what people fail to realize, I know people complain, and I'm not criticizing anywhere else. They complain because their hospital's shutting down 40 minutes and they maybe have to travel 75 kilometers to get to a hospital. Well, in Grande Cache, we have to go 140 is our closest direction if we go to Hinton, and 180 to get to Grand Prairie. And there is no other communities in between. So I think that was, we just had to do it. And if nobody else was going to help us, that was the problem. We did tons of advocacy. Nobody else was going to help us. So this was the way it worked.
Both of you, what would you say is the biggest barrier that you face in getting the clinic up and running?
Some of the issues that we had was funding, mostly because we, first of all, weren't sure where to go to get funding. We knew that within our community, yes, we would have some backers, but because we're so small, and yes, we do have some big oil companies, but everybody's feeling a pinch. So by going to the MD and approaching them first, that gave us at least some hope as to moving forward. But we've applied for numerous grants and through government grants and stuff, but there's only 3 usually criteria that they will not give money for. One of them is running a medical facility. And so all of that grant money that we've applied for, we've never gotten. So it's been quite a scramble to try and financially figure out how to keep this clinic sustainable. And the other thing is we had 5 doctors originally. So we based our business plan on 5 doctors because for one thing, that was what we had. The other thing is this actually went into Parliament at one point in time, and it was suggested at that time through their discussions that we would need 5 to 6. So we have based our business plan on 5 physicians. So sustainably at the end of 5 years, we would be pretty much self-sufficient. Unfortunately, we have not had that. We've only had 3. We had 4 for a little bit of time and 3 now. So we're not sure where we're going to be in the 5-year program, and we're of course starting to look at that now to see how our sustainability is going to last at the end of that 5-year period.
Mm-hmm.
And one of the questions you may be asking is, how much money did the MD give us? They gave us $250,000 as startup, and then $50,000 a year for 5 years. And so the money they give us helps keep the clinic afloat, but we are still losing money every month at this point in time. And we want to keep that's our attraction point. We want to keep our overhead for the doctors low. They don't have to do anything. They just come in, they work. They love that part because they don't have to run a business. We're doing everything for them and totally all volunteer. but they don't want their overhead to go up, but we need to keep the clinic running. So it's really, really sometimes tough.
Mm-hmm. So what would you say is some of the key factors in making this particular initiative successful, and what has changed in your community thus far with it?
Well, I would say the biggest thing would be our partnership with the MD.
Mm-hmm.
That is the one thing. We've got a very strong board, and they're giving a lot of time. We've done a ton of advocacy letters. Some of our community businesses have given us some money.
So just to wrap up kind of your panels and the questions here, what's one lesson that you'd want other rural communities to take from your experience in this?
I think the one lesson would be is if communities work together, they can accomplish a lot. And if anything, we've proven that. And considering our rural, where we live, really, we're kind of in the middle of nowhere.
Mm-hmm.
So anything is possible. You just need that cooperation and that help from everybody to step in and to do that. And hopefully, like I said, we're working hard, and we're hoping that even at the end of that 5 years, we're still going to be good to go, because we need that we need physicians in this area no matter what. And at least we're lucky enough that we have some, and
Yeah.
many places don't.
Yeah, we have 3 physicians right now, and I think it's also important if you decide to form a non-for-profit and it's volunteer, you have to get the right people on board. So it's really easy to say, "Oh, let's get all people who are in healthcare," but you need a businessman on there. Like we have a pharmacist who has a business degree. I'm educator, but I've managed lots of budgets and whatnot. Tina is a healthcare worker. We have a person who used to work at the hospital as a manager. We have a variety of different people on our board, and that's what helps make us strong.
Yeah, so you would say the kind of the diversity in the membership and everybody working together in those partnerships is a key takeaway.
Exactly.
Yeah.
And we actually got very lucky, because none of the people that accepted to come onto this board was just, hey, do you want to come and give us a hand? Was, yeah, sure, why not? So as it ended up at the end of the day, we were lucky enough that the people that ended up on the actual board, because we had a lot of people that were discussing and trying to figure out how to go, right?
Mm-hmm.
But the people that we ended up with on the board work extremely well together, and every one of them comes with some type of knowledge and help bring this board forward. So as Jackie was saying, with business, with healthcare, with managerial, with budgets, we also had somebody that was very adept in HR and did all policy and procedure manuals, all that stuff that you never think of when you're actually forming a board or a business or a clinic from the start, because none of us have really been into the clinic aspect of it versus the actual working in healthcare or running, a pharmacy, whatever.
Yeah.
So we were
And
very lucky that way.
yeah, think like Tina had said yesterday to me, we have to think outside of the box. And I mean, we're constantly coming up with new ideas. We're starting to work on getting other professionals.
Well, thank you both so much for sharing your experience in Grande Cache. And I think it just shows the unique aspect of your location and the forward-thinking mindset of those in the community and seeing a challenge and honestly just figuring it out. I think that that's something that many rural communities face. And I think it's just that go-getter attitude that will see it to be successful. So thank you so much. And if anybody does have questions for Jackie or Tina, just do put them in the chat and we will get to them at the end of the panelist discussions. So thank you again.
Thank you for having us.
Now we're going to shift to Athabasca and Boyle. So joining us representing the Regional Healthcare Attraction and Retention Committee are Robert Boyle, who is the chair of the committee and current mayor of the town of Athabasca. Robert was instrumental in forming the regional committee and has championed initiatives including transitional housing for healthcare providers, community appreciation events, and student engagement programs. We also have Shelby Kitley, Boyle representative on the regional committee and a 3-term elected official. Shelby is a strong advocate for rural healthcare access, including efforts supporting the reopening of Boyle Hospital. A funeral director, a business owner, and a mother of 3, she brings both professional and personal commitment to community well-being. So thank you both for joining us today. And we are going to start off your panel discussion, kind of the same questions. So tell us about your community and the healthcare challenge you were facing.
Sure, I'll begin, but I think with each question we'll both answer because we're a bit unique because we have two hospitals, one Athabasca, one in Boyle, with both have different I guess problems to try and solve. So basically Athabasca is about just under 3,000 people, but our committee represents about 12,000 population all around from all the different municipalities. Originally with Athabasca. We had one of the issues we had was we had some older physicians that were no longer willing to do the ER rotations, which was putting lots of pressure on the remaining doctors. And as Shelby will relate to later with the problem in Boyle and the fact that their ER was closing, that only compounded the problem in Athabasca because everyone was then coming to Athabasca. So that's basically what sort of drove it to begin with. And I'll turn it over to Shelby.
Boyle is a village. It's just under 1,000 people, but the service area is much larger. We have two summer villages, a large farming community. Highway 63 runs through, which is a very busy highway. We went down to 12 hours a day of emergency. We were previously open 24 hours a day with acute care and a palliative bed as well. So there was no more acute, no more palliative. All of our residents at the hospital were moved out of town, making it inaccessible to their families often. They were not able to get the support that they needed close to home anymore, and which also had a snowball effect. We were unable to get locum doctors. The janitorial and food service people were put on hold for a while, so it was affecting local jobs as well as the well-being of our community members.
It's so interesting because each rural community is so unique, and how we approach that is key too. So I'm excited to hear. So what was the moment that when your community realized that something had to change?
But, when the younger doctors came and said, we need to try and do something here because we're worried about long-term burnout and trying to keep the doctors that we had. At that time, we had 7 doctors, but 2 weren't in the rotation. It was difficult at times to bring in locum doctors to, I guess, help support that. And so that's when we decided that we needed to take some action as far as the Athabasca situation.
For clarification, the issue in Boyle started with our difficulty getting RNs in the community. We had always been fine for doctors doing the on-call rotation. So our closures in the evenings were due to RNs. And it was supposed to be a fairly temporary closure. And after 6 months, we met with the minister, and they had agreed at that point it was too long already. And it ended up kind of going for 3 years in the state that it was in, which the more we could see the morale in the community going down, we could see the morale for the staff in the hospital having their hours cut. So we just knew we had to start to be something bigger than ourselves, to start shaking all the trees we could and figuring out how, as a small municipality in such a big sea, we could band together and do something that's not traditionally up to the municipality. Because up to that point, the province had everything running smoothly. And while we were big supporters and proponents of our hospital, we had never really had to figure out how to be involved. So that was kind of our turning point, is we all have one goal, but how are we going to do this?
So how did both of you recognize, so there's that problem, but how did you make it into action? What did that look like?
Basically, what happened was I started getting in contact with, as a council, we decided that we needed to form a committee. And so we initiated invites to all the municipalities around, which was the Village of Boyle, Athabasca County, the MD of Opportunity, Buffalo Lake Métis Settlement, and later we invited the summer villages. There's 9 summer villages that surround both the Athabasca Hospital and the Boyle Hospital. We got together, formed the committee, invited 4 members at large. On the committee as well, there's the site supervisor, RhPAP. Anita has been a big help. When we initially did our terms of reference, we relied quite a bit on Anita and RhPAP and the resources that they were able to supply for us. And then once there's some physicians that are on there, there's some nurses that are on there as well. So I think we're well representative to make decisions and to brainstorm. And basically, once we had the committee formed, we started holding meetings and began brainstorming ways to both attract and for retention. So basically, that's how it got started. I'll turn it over to Shelby.
Yeah, so we attended the information sessions that we were invited to by Athabasca and Athabasca County. Regional approaches and strength in numbers seems to get the best results. So it was just kind of a no-brainer to attend that. We had also had the opportunity to speak on some healthcare panels, just outlining some of the struggles that rural communities had been facing. And that was a really great opportunity to network with people outside of the region and just figure out what's working for them and what's not and get some contacts. We also started speaking with the senior administration at our hospital. They've been really great contacts and really helpful as well. And just trying to get enough people together to, push the human side of the closures as well, rather than just being another statistic on paper in the AHS pool.
I'm curious too, because I know both Athabasca and Boyle, they have a sort of training program for internationally educated nurses. So I'm wondering if either of you can speak to that. Like, how did you identify that that was needed, and how did you get that coming to fruition?
I can take that if you don't mind, Rob.
Sure.
So we were actually successful in being chosen to be one of the communities that hosted the first round of internationally educated nurses, which we knew was going to be a blessing that came with many challenges. And boy, were we ever. Actually, Doris, who's joining Rob today, and I had worked in partnership of integrating nurses into our community. But we found that the first round came completely unprepared. The program was created by people who were often from larger centers that didn't understand the struggles and barriers that people in smaller communities face. So unfortunately, our first round of IENs was not successful. Neither are still in our community. So something needed to be done that way. From a committee standpoint, Doris and we got together and kind of made a one-pager of what worked and what didn't in terms of integrating the services they would need, kind of the order in which you need to do things. But in terms of the actual formal on-site training, Angela, who's on the call, created a program of training that seems to better suit the IENs and getting them transitioned professionally within the hospitals.
So I don't know if Angela wants to skip on and say anything. We'll give her a chance to prepare, and if she will, that would be great. But also, I think in Athabasca there was issues with finding housing. So we finally decided to purchase a house that we could use, that would always be available for when we had last minute placings. And currently right now, I think there's 4 IENs staying in the transitional house, which is within walking distance to the hospital. So that's the location was great. One of the things that I was surprised to get some pushback with the whole program was local people who wanted to work weren't not being offered jobs because those jobs were being saved for IENs. And so, we heard a little bit of pushback. I don't know if that happened in Boyle or not, but it definitely happened here in Athabasca. But since then, we've managed to work through that. And I don't know whether Angela wants to speak a little bit. I hate putting her on the spot, but if she's in her pajamas, she can leave her camera off.
She just said she's willing.
You
Okay.
did say she's willing, so yes.
Okay, good. Sorry.
Oh, it's okay.
Go ahead, Angela.
Hi, thanks. Not in my pajamas. I was prepared. Thank you. I like that though.
After the first two staff, like Shelby had mentioned, came and really struggled, I think, in just coming on onboarding and just working as a registered nurse, we identified that there was a gap in their onboarding to rural. Rural is not, it's its own specialty. We don't just do obstetrics or ER or med surg, we do them all. So it's a very broad scope for nurses to take on, just in general, even for local trained new nurses coming to rural can be a challenge. In seeing that, I tapped into our site supervisor. She definitely supported us in doing some development of a program that blended some classroom training with clinical hours. I had suggested we bring on a clinical nurse educator from AHS who has her master's in nursing and nursing education in particular. And she and I paired to design what became a 12-week training program that led the nurses through everything from AHS onboarding to specialty skills in the ER across like a continuum of training. We did a couple of days in classroom each week. The rest of the week, because the staff were full-time nurses, and I believe that AHS sponsored them to come to Canada under work visas for healthcare, so they had to give them full-time work. That's what I understand. So they had to guarantee that they got full-time hours in order to do that. So to make up the balance of their contracts and to meet the Canadian requirement, they worked clinical hours for the balance of the week as well. So they were doing some classroom training and then having some time with preceptors and buddies on our units to integrate those skills. And through that, we now have one of our nurses has launched actually a year ago, probably now, to Boyle. So Godfred is there in Boyle, and Wumi is in Athabasca, and they're doing very well. And we have done, I think we have helped out 10 nurses so far through that training program. One is in long-term care, one is in home care, and the rest are Boyle and Athabasca. We have 2 more nurses in ER preparation right now at our site who will launch to Boyle shortly. So that will be Mark and Esther, whom Shelby, thank you for helping them in the community.
No
Esther
problem.
was so complimentary of the help that you gave. The other thing we found was maybe that classroom gave them a point person to come to when they had issues, even with clinical stuff or whatever. So like supporting them. I know that the community supported as well with some things to integrate them. Maybe Shelby and Mayor Belay and Doris can talk to those pieces, but they also paired with us like to the clinical side. The staff have, I think, done extremely well, and you can walk into, I know in Athabasca now, because of the number of staff we brought on, there's always going to be someone on shift now who went through the training. So you're always going to see someone. So they're filling gaps that we certainly did have. And I know that it took some of them years to get here. So the progress of them starting to come to Canada to them actually arriving has been a 2 and 3 year process for some of the staff. So I think we did have some local staff who felt displaced, perhaps because of that. I can't speak to all of the things like that, but because they were guaranteed full-time work here, whatever, under immigration that had to be met. I think they're still working on marrying those things up, and that people are retiring and jobs are coming available. So we're very grateful to have both our local folks. I taught an LPN program for a while as well here in community. For Northern Lakes College, and we did always recruit some of those staff to our site. So we fill gaps from various places, but it's been a privilege to work with the international nurses and help them onboard clinically from my side for sure. If anyone has questions, feel free to ask. That's kind of the nuts and bolts of what we did.
You know, from what Shelby had talked about, all the things that were missing when the first ones came. So we learned from that. We decided to come up with a community volunteer adoptive helpers for each nurse or each family that came. And so we identified people in the community that we felt had the skills and the resources that could help them. And we paired them up individually. And depending on whether it was a single nurse or a nurse and a family that had children, we tried to pair them up with a community person that, probably would be able to help them the most. And I think that helped to transition them into the community. And it's very important, especially for the first, 1 to 3 months, to get them so that they're feeling somewhat integrated, and then they always know that they have someone that they can rely to and call on when problems pop up. So I don't know if you can want to add to that, Shelby.
The only thing that I'll add is, like I said, we had made a one-pager to give to our adoptive families, if that's what you want to call them, to our IENs. And if there are any communities on this call that would like to have it just as a resource ahead of time, if you're expecting an internationally educated nurse, we are willing to share it.
Just in the interest of time, I have one last final question for this panel. So what is one lesson that you would want rural communities to take from your experience?
I think that one lesson to take away, especially if you're from a smaller rural municipality where it kind of seems impossible that you're drowning in this larger province, is that relationship building is so important. It takes time. Hospitals don't see municipal boundaries. It's not just people from Boyle that are using your hospital. So network out. You'll find that it's important to a lot of people, and the more support that you can get from within, the louder your voice is going to be on the broader scale. And then when it comes to bringing in an international person, be realistic with them. I mean, we all think our communities are great, or else we wouldn't be in the positions we're in, but you also have to be realistic and let them know some of the challenges that, you're going to go to work in -40 and transportation might be an issue, and just little things like that. So you can help mitigate the challenges before they're really causing problems in their lives. These are real people with real feelings coming to your community, and you need to be mindful of that as well.
Yeah, and just to add to that, I guess, whether it's a physician who's an international, took their training internationally, or it's one of the nurses, it is all about building relationships with them, and right from trying to attract them, and then once they do come, it's even more important, for retention. We were pretty lucky. We were able to take advantage of the Reside program as well, and have one physician under that program. We've recruited a total of 3 new doctors to Athabasca, and I believe 1 to Boyle. And we've also we've been fortunate enough that a local person has become a nurse practitioner and is just beginning to open her panel. So we're open to that. That's worked out really well. And we were also successful in getting a young married couple that are both nurses to come and work here as well. So we've had some success. We've learned some lessons along the way too. So it's you're always learning lessons. I'll tell you that. So
Absolutely. And we did have a few wins in Boyle as well. While we're not back to 24-hour emergency operations, we did manage to get 5 acute care beds open and a palliative bed, and they've all been full since then. So we've still got a little bit of work to do, but it just shows that if you're moving forward as a collective whole, I mean, you're going to get some success.
Thank you so much to all 3 of you. I wasn't expecting Angela to come on the call, but that's fantastic. I know that your program, especially in the training program, is something that is highly relevant across the board. So I'm sure you're going to get a lot of follow-ups to that. But thank you so much for sharing your stories around Athabasca and Boyle. Our next community in terms of panelists is Rocky Mountain House. So joining us from Rocky Mountain House, we have Heather Halliday, registered nurse with more than 20 years of rural practice experience. Heather has advanced training in emergency nursing, a master's in health studies with a teaching focus, and is well known locally as a mentor and community champion. She is the past chair of what is now the Rocky Mountain House in Clearwater County Community Wellness Team. We also have Lori Pratt joining us today. She is the chair of the Rocky Mountain House in Clearwater County Community Wellness Team. Lori has deep roots in the community and has played a key leadership role in transitioning the former health professions engagement team into an independent society focused on community wellness and healthcare advocacy. So welcome to both of you. And I'm going to jump right into your panel questions. So Heather and Lori, tell us about your community and the healthcare challenge you were facing.
Rocky Mountain House is a beautiful, I'm going to call it a fringe rural community because we encompass a lot of a very diverse area, as all rural communities do. However, there's nothing really between Rocky Mountain House and Clearwater County and the BC border. It's a very large area. We encompass 3 First Nations within our health area. We have tons of rural communities, and just a lot of people we have more people that live rural than actually live in town. So it's very diverse. It's very popular as well as a exploration point for thrill seekers with going out and doing things like snowmobiling and backcountry skiing and that kind of thing. So, that can provide quite a diverse, interesting amount of health challenges that end up at our hospital in Rocky Mountain House. And Heather, would you like to add to that?
Just that our town is roughly 7,000, catchment area about 20,000. Yeah.
Okay. So what is the challenge that you would like to talk on?
Well, I think probably what I would say, and I think all rural communities would agree with this as well, is one of the biggest challenge we have is advocacy and being heard rurally, and we've seen that, and we have a couple of examples of how we've handled that, and one of them is around the operating space and making sure that we had a operating space at Rocky Mountain House, and another one is making sure that we had enough people that wanted to live here. So bringing in more staff, making sure that was happening. But one of the biggest things that we're also finding that is a current advocacy, it's an ongoing, is around privileging as well.
When did your community recognize that, oh, you know what, we need to do something about this? Like, when was the turning point?
Well, for example, the operating room, the new build operating room, that's a really great concrete example that we can speak about right now. Is that was at least a decade in the making before of advocacy by not only local groups, but our local politicians to our MLAs over the years, over that decade, really advocating to the government about making sure that Rocky Mountain House had a dedicated additional surgical space. And it took until 2021, and with when the stars aligned with the Alberta Surgical Initiative, that's when it finally was decided that Rocky would be getting $10 million to build a new operating room, which has been, it's been greatly used. It opened in 2024, but we've still had additional challenges with that. And Heather, over to you.
Yeah, so we did have one small operating theater and a medical reprocessing department, neither of which were kind of meeting current standards. So when we had our accreditation programs go through, there were deficits that we couldn't address without a build. We were advocating for Rocky Mountain House. I really relate to some of the other panel speakers with Grande Cache in terms of where you sit, and that if your site doesn't offer these resources, people have to go a long way. So we do have a First Nations community that's about an hour and just over an hour away from Rocky, which means that they are over 2 hours away from Red Deer if surgical capacity is lost in Rocky. We also know that communities don't lose their surgical capacity temporarily. So if you lose it, it's gone and you're not going to get it back. So when we were looking at what our options were, do we take obstetrics out? That leads to the death of a surgical program. Or can we somehow revitalize this program? We were really needing to advocate and work in the dynamic of a centralized system in the central zone, where Red Deer really did want to retain a lot of the surgical capacity for the central zone, with the idea that the more surgeries they did there, the more of a strong case they had for expanding their capacity. So yeah, just lots of advocacy on the local front, speaking with our MLAs, having people come and tour our facilities to really understand what we were dealing with and how we were offering excellent care, but in suboptimal facilities, and that we needed to move forward to be able to expand. As Lori said, it really, at the end of the day, I don't know if that advocacy would have ever been enough. The Alberta government decided that they wanted to expand this rural initiative so that they could decentralize some of those surgeries and try to reduce wait times. That was when the balls really started rolling. And so that we got a big, beautiful OR. We're in the process of construction of the second OR to really revamp that as well, to have two strongly functioning operating theaters. But yeah, I think all the way along, we've been able to leverage the strengths of the people on our team to advocate in ways in their zones of influence, in their spheres of influence. So it's always been important for us to have community members, to have healthcare professionals, and also to have those elected officials and representatives who are all kind of championing at the levels of influence that they find themselves to try to advocate for what our community needs.
In terms of the barriers, so at the community level with your advocacy, what would you say were some of the key barriers that you faced, and how did you work through them as a community?
Staffing, with specific to the operating room, that's one piece that we found with is making sure that we had the staff in place as well, and that we had the beds, and we do have beds. Some of our beds are not open because we're just coming back up to a full complement of nursing staff at the hospital. We've been our new ED director. She's been hustling hard to get what she can in there. One of the bigger barriers, though, we have found and has really been within the central zone. Is the privileging that I happened to mention earlier. It's been really a difficult thing for us to get around, because there's so many different layers and levels to this. We've lost a surgeon because of privileging difficulties that way. And that's where our local elected officials have really helped to come into play, as well as our MLA, is getting everybody in the room to find out exactly what the issues are, and being able to speak with internal management staff within the system as a whole outside of our area, or that might be able to exert additional influence. And really, but that's that's one of the bigger issues. One of the other things that we're finding right now, and Dale Chappelle, who's one of our counselors that sits from Rocky Mountain House that sits at our table, he would have been here, but he's actually on another meeting advocating for more operating room dollars because we're now, with the second renovation, with the renovation of the second room happening right now, we're also needing additional space, and we also are looking at that staffing level. Heather?
The privilege thing has been going on for a long time, and we continue to push hard for that. And I think we're happy to talk about that more if individuals have questions and that kind of thing. But more broadly, from a staffing perspective, I did want to touch, especially related to Athabasca and Boyle's experience with IENs. I lived in High Level and worked there for several years, and we had a batch of IENs 15 years ago. So when this came around again, that the government really wanted to push these international nurses, I approached it with trepidation, knowing that I guess the optics are better from a political perspective in terms of these people can come in and hopefully within 1 or 2 years we have nurses on the ground. But what I'm more interested in are growing our own nurses, and these men and women who grow up in the community and are more likely to put down roots in the community. We have a lot of these people who are in their 30s and 40s and 50s who grew up in Rocky, started families in Rocky, farm in Rocky, all of that, and are staying here. And so my heart has really been to try to find those people as high school students, to have them really take a look at nursing, healthcare professions as an option, knowing that we will have much more long-term success with them than we will with our IENs. We've worked really hard, really appreciated hearing some other approaches with the IENs, but the success is always going to be limited, and the selection process has not evolved much in the 15 to 20 years that I've been involved with it, in terms of getting these nurses who come from the capital of Ghana to Rocky Mountain House. There still isn't awesome pairing happening in terms of, okay, let's connect our rural nurses to rural sites and our and the people coming from giant cities to the cities we have to try to really facilitate retention. So we see that as a barrier. We are working at a community level to try to really help these nurses transition in. But knowing that at the end of the day, if I can take someone who has grown up here, who lives here and loves the community, and really open up the idea of health professions to them, that I have a much better chance of having them stay here. So we have done the post-secondary events where we come and let's go rural. And RhPAP has been amazing. I just want to call that out. I didn't know other people have, for providing these programs where we can just bring them, where they're like, yep, we've got the dollars and the know-how and the equipment. You just, fill in those other pieces and bring post-secondary students to rural places. This is something I didn't have any exposure to when I grew up in Edmonton. And I was lucky to find myself later on in life in rural places, but a lot of students don't have the exposure. So that's huge, as well as our lunch and learn sessions, which we're doing with our high school students. Let's Go Rural programs with high school students to expose them to all of the healthcare potential that there is, with the hopes that they will stay in their community.
And those lunch and learns that we do at the high school, we bring in emergency services, we bring in nursing, we bring in physios, so that way they understand that, healthcare is more than a doctor or a nurse. There's just so many different areas that services are needed.
In terms of the efforts that you've put forward and kind of the results that you're seeing in Rocky Mountain House, what's a lesson that you'd want other rural communities to take from your experience in this?
One of the things that I'm really passionate about and was passionate about as chair is leveraging your team's strengths. We in our team, and Lori can speak better to what's going on right now, but we would have community members at large. We would have counselors from the county and the town, and health professionals like myself, really just exploring what the passions, strengths, and spheres of influence are for those people, and strengthening them to be effective in those places. I don't need necessarily my community at large member to try to be accessing the MLA in the same way that my counselor can. So I can leave that there, but I can have them be doing really incredible things kind of where they live and the that sphere of influence is really important. So that's been a big takeaway for us, because I just think I've had a lot of trials and failures in terms of trying to plug people in certain areas, and at the end of the day, just looking at where they come from and what they're passionate about. And then from our team perspective, really developing strong subcommittees, so that yes, as a team, when we get together, we're talking about high level things, but the real work happens with these subcommittees, with people working in areas that they're passionate about, with smaller groups, and trying to get things done.
Don't stop. That's the one thing I've learned is, the persistency and the consistency. Mm-hmm. And like Heather says, playing to the strengths of the people that you have on the team has just been incredible. And we're very blessed that we have, our counselors on that are just working so hard. We have our healthcare professionals that sit on, and then we have the executive director from the Chamber of Commerce. We have, and we're opening it up, and we've put out invitations to our school division as well to send a trustee to meetings too, because there's certain places, especially as Heather said, starting at a student level, and if we can, there's the college university level, but there's high school students that aren't sure what they want to do yet, or they do know what they want to do, and if we can get the school divisions on board as well, let's really let's expand.
Mm-hmm. And that's part of the beauty of rural communities, is that we can sit around at our tables and identify a need. And someone around the table will say, well, yeah, that's Louise. We need to get Louise involved. Or that's Bernard. And they know who, like between the 8 of us or whatever, everybody knows everyone in the community and knows who to pull in. That is a wonderful thing about what rural communities have to offer. And we just are always trying to do a good job of leveraging that and pulling the right people in.
I just want to thank all of the panelists today. That was fantastic. We do have a few minutes to get into the Q&A. And I see there's 2 questions. So I'm going to bump up to the first question that was in the chat. And this is from Monica at Crow's Nest Pass. So I think this is for you, Robert, around the transitional housing problem and how Athabasca kind of helped that out and solved it.
Sure. We partnered with Athabasca County, and so a recommendation came from the committee to both councils to say that this would really help with for both attraction and retention. So then we convinced both councils to invest money. So it was a 50-50 split to find a property that was close to the hospital, so it made it very easy transportation wise and very close to the WIPS primary school. So it killed a couple birds with one stone for that. And as it turns out, it's been a cash positive venture. So we've actually, there's money and it creates more money than it costs. And eventually, it's also, the value of the property is only getting better, not receding. So we felt safe that it was doing that. In Boyle, there was already an agreement between the county and the village about providing housing for nurses and for locums. So, it's through collaboration with your municipal partners that you actually can get stuff done, because it would be hard for us as a smaller municipality and the village as well if the county didn't come on board and support us. So that's how we got it done.
And just to add to Boyle's, we didn't purchase a property. That was just not within our means at the time that we were looking at. So we have 2 rental properties, one very close to the hospital for nurses. So any locum nurses or internationally educated nurses having problem finding somewhere to stay can stay at that location. And then we also have a rental apartment for doctors when they come into town. And that is in collaboration with the county.
And so does the county have that rental agreement, like overarching?
So Boyle has the rental agreements, and then
Okay.
the county cost shares with us.
Gotcha. Okay, nice. Thank you. That was just for me. That's clarification for me, but thank you so much. I'll get to one last question. So this is for Heather. So Josh said that you mentioned coming from Edmonton and eventually ending up working rurally. Do you have any ideas on how we can present this to students from the city and have them retain that interest to go and practice rurally?
Yeah, great question. There's nothing like the exposure. So whether it is a Let's Grow Rural program, I think every community in Alberta should take advantage of what RhPAP is offering in terms of having, so that I don't know what the selection process is, but we had med students, pharmacy, physio, nursing, I believe OT, that were selected somehow, put on a bus and came to our community. If every community did that and we just tapped out RhPAP's resources, it would be a fair bit of exposure, right? And even if the students didn't directly go to communities, the word spreads. Even if they don't end up in our community, if they think, man, I never thought about rural and maybe I should, that's a win. It's a huge win. I think that some community or some university programs do better than others. So my experience teaching with Red Deer Polytech was great in terms of sending people rural, but I think that we can advocate to the urban post-secondary institutions that a rural experience or even just offering it to students is a great opportunity, because it really does often just take them seeing it to open up their eyes to what it could be and what it could look like.
Yeah,
I guess one more thing too. Yeah, one more thing too, I guess just going maybe to some of the career fair. We've done that in the past. I don't know if that's going on now, but to just go to those places and just talk to them about what rural nursing is. Someone mentioned, you know, that it's its own specialty because of all the breadth of experience that we have. So that can be something that urban students have never really thought about unless we're in their face kind of talking to them about it.
Mhm.
I could
That's a
add
great point.
quickly to that too. We have a couple of doctors that actually go and go to Red Deer and to Edmonton to U of A and actually take the third and fourth year med students out for lunch and promote rural our community in particular, of course, but you know, it's also just for all rural communities, and I think that's a great way to do it as well. It's specifically for that. And not that we get money from RhPAP, but our committee chose to do that. But I have to admit that our RhPAP is a tremendous resource, and more communities should try and take advantage of what they have to offer. So thanks.
Thank you so much. Yeah, that's great. And in terms of students and getting them out there, we currently do have our expression of interest open for RhPAP for the high school events as well as post-secondary. So if your community or committee is interested in hosting one of those with RhPAP, please do put in an expression of interest. We always take them very seriously. And when Heather was talking about how students are selected, generally if the community is selected, we have a touch point with a site manager or healthcare professionals there to see what are the openings that are in that rural community. And then we will try to pair students in those particular programs with the needs of those communities. And those are the students that we bring out. So it is very strategic in that. And then still, you know, giving the breadth of the healthcare professions that are out there, we still do give opportunities for various health professions. So that's kind of the inner works of how RhPAP does it. So I wanted to highlight that a little bit as well. But it is time, so I do want to say that as we wrap up, I do want to sincerely thank our panelists from Grande Cache, Athabasca, Boyle, and Rocky Mountain House. Your leadership demonstrates that rural healthcare success isn't driven solely by systems. That's obvious. It's driven by people, relationships, and communities who decide to step forward rather than taking a step back. So to everyone who joined us today, thank you for the work that you're doing in your own communities. We hope today's stories spark ideas, strengthen confidence, and reinforce that grassroots action truly makes a difference.